Today's high-yield focus is on Rh isoimmunization, a key topic for PLAB, MRCP, and USMLE exams. Let's begin with the pathophysiology. An Rh-negative mother carrying an Rh-positive fetus may be exposed to fetal red blood cells during events like delivery, trauma, or procedures. This exposure is known as feto-maternal hemorrhage. The mother's immune system recognizes the Rh-positive cells as foreign and produces anti-D IgG antibodies. In subsequent pregnancies, these IgG antibodies can cross the placenta and destroy the red blood cells of an Rh-positive fetus. This leads to hemolytic disease of the fetus and newborn, or HDFN. A key fact: only IgG antibodies can cross the placenta. IgM cannot. Now, what are the events that can sensitize the mother? These include delivery, amniocentesis or chorionic villus sampling, antepartum hemorrhage, abdominal trauma, ectopic pregnancy, miscarriage or abortion, and external cephalic version. Let's talk about screening. All pregnant women should be screened at their booking visit, around 10 weeks of gestation. This includes determining the ABO and Rh blood group, performing an indirect Coombs test to check for anti-D antibodies. If the mother is Rh negative, repeat testing at 28 weeks to monitor for sensitization. These are core facts. They're not only common in exams, but also critical in real-life clinical practice. Let's now cover prevention, diagnosis, and management of Rh isoimmunization with key exam facts for PLAB, MRCP, and USMLE. Prevention with anti-D prophylaxis. Indication: Rh-negative mother with an Rh-positive fetus, or when the father's Rh status is unknown. Anti-D IgG is given at 28 weeks and again within 72 hours after delivery, also after any sensitizing event beyond 12 weeks gestation. The dose is adjusted based on the Kleihauer-Becky test, which estimates how much fetal blood entered the maternal circulation. Diagnosis in sensitized pregnancies. Start with maternal anti-D antibody titers. The critical threshold varies by lab. Then, fetal surveillance. Doppler ultrasound of the middle cerebral artery, or MCA Doppler, is the gold standard. Increased MCA peak systolic velocity suggests fetal anemia. If needed, perform amniocentesis. Measure delta OD 450 on spectrophotometry to determine the Liley zone. For definitive assessment, use cordocentesis to directly measure fetal hematocrit and to perform intrauterine transfusion if necessary. Management of the affected fetus. Fetal anemia? Treat with intrauterine transfusion. Plan delivery based on the severity of anemia, fetal well-being, and gestational age. After birth, monitor the neonate closely for hydrops fetalis, severe hyperbilirubinemia, which can lead to kernicterus, and anemia, which may cause heart failure. Complications to memorize: hydrops fetalis, stillbirth, neonatal jaundice leading to kernicterus, and neonatal anemia leading to heart failure. This is high-stakes medicine and high yield for your exams. Question 1. A 28-year-old woman, Gravida 2 para 1, is Rh negative and has anti-D antibodies detected at a titer of 1 to 32. What is the next best step? A. Give anti-D IgG-B, monitor fetus with MCA Doppler. C. Perform amniocentesis immediately. D. Schedule cesarean delivery at 34 weeks. Correct answer: B. Once a mother is already sensitized and has developed anti-D antibodies, giving anti-D IgG is no longer effective. The fetus should be monitored for anemia using middle cerebral artery Doppler, a non-invasive and reliable method. Question 2. A woman has a spontaneous miscarriage at 10 weeks. She is Rh negative. What is the appropriate management? A. No treatment needed. B. Give anti-D IgG. C. Give corticosteroids. D. Check maternal hemoglobin levels. Correct answer: B. After miscarriage, anti-D IgG should be given to Rh negative women to prevent sensitization. This applies even in early pregnancy. Question 3. Which immunoglobulin mediates Rh isoimmunization? A. IgA. B. IgM. C. IgG. D. IgE. Correct answer, C. IgG is the only immunoglobulin that crosses the placenta and causes hemolysis of fetal red blood cells in Rh isoimmunization. IgM does not cross the placenta. Question 4. Which test quantifies the amount of fetal blood in the maternal circulation? A. Kleyer-Betke test. B. Coombs test. C. Liley curve. D. MCA Doppler. Correct answer, A. The Kleyer-Betke test estimates the volume of feto-maternal hemorrhage and helps determine the correct dose of anti-D IgG needed. Question 5. When is anti-D typically administered during pregnancy in a non-sensitized woman? A. 20 weeks and at delivery. B. Only postpartum. C. 28 weeks and within 72 hours of delivery. D. Every month starting from 20 weeks. Correct answer, C. The standard prophylactic regimen is to give anti-D IgG at 28 weeks gestation and again within 72 hours postpartum if the baby is Rh positive.